But I want to tell you the story that set me on the career path that I'm on today. The woman to the right is my mom. My mom is 78 years old. She was a nurse. She was a nurse. She's still alive. I don't want to speak of her in the past tense. But she was a nurse in New York City. Standing next to her is my youngest sister, Felicia. My mother, as I said, was a nurse in New York City, and my sister Felicia was the seventh of her children. And my mom had a really bad experience with the birth of her sixth child. Just too many rules and restrictions and regulations even back then in the 1970s. So much to the point that my mom said, "Forget y'all, I can do this without you," and told her OB when she was pregnant with her seventh child, "I'm having this baby at home. You can choose to show up or not, but that's where I'll be." And this is in New York, so not exactly the natural, organic, home birthing type community, but my mother is my inspiration and my role model. Second only to her is my sister Therese, who's a fellow physician, although she's a trauma critical care surgeon, about the exact opposite end of the medical spectrum as you could get from family medicine. But I want to share the history of what brought me to where I am today. As the physician said in my introduction, this experience, witnessing the birth of my baby sister, is the day I tell people was the day I decided I was going to become a physician. I knew it hands down. I was 8 years old, and this is what I was going to do. And within a few years, I knew that I was going to be a family physician. I loved the idea of caring for women and children and grandparents and siblings and the whole concept that was so important to me. So as he said, I graduated from Cornell and Stony Brook and did my residency in Lancaster, Pennsylvania, where we learned to do full spectrum family medicine, and then left there to go to Washington, D.C., because my husband was doing a fellowship at Georgetown, a medical editing fellowship. His name's Dr. Kenny Lynn, and he's one of the editors for the American Family Physician Journal. He also has a blog called Common Sense Family Doctor. So anyway, we went to Georgetown, and I worked in a traditional community health center, an FQHC, where I was expected to see 11 patients in the morning and 11 patients in the afternoon. Many of these patients had Medicaid or Medicare or private insurance. Many of these patients did not speak English. Many of these patients had multiple issues, and it was really, really hard to take care of their needs in such a limited period of time. Flash forward a few years, I had an opportunity to become medical director of the Catholic Charities Health Centers. I had a background in health administration, which some people might see that as a negative, but I thought it was a good thing because it allowed me to work at this clinic where, again, we served an exclusively poor and insured population. And this experience was transformative for me as well, because it showed me how much healthcare costs. When you have patients that don't have two nickels to rub together, that were able to contribute $32 for each visit that they came, and I discovered we had negotiated with the labs to get a cholesterol panel. I never knew a cholesterol panel only cost $4.26. It's like, why do my patients get bills for $90 or $120? So this experience, and especially in caring for the poor through direct pay, realized this could happen for everybody. Now, I am a family physician. I am still a member of the American Academy of Family Physicians. I just renewed my membership under the wire, and every year I have to evaluate this. Because in 2010, after having been at Catholic Charities for a couple of years, 2009, it was around the time of the Affordable Care Act debate, and the leadership was going on and on about how great the Affordable Care Act was going to be, and people would say to me "Oh, you must be so happy, your patients are finally going to have insurance," and I thought, no, most of them are undocumented, they're not, it's going to make my job harder. But the Academy had this big town hall meeting, probably 5 times the size of this, and they were going on and on about this wonderful plan. And I said to them, I got up to the mic and said, well, what about direct primary care? What is the Academy doing for physicians that are interested in this? Because I was looking for other people that were doing what I was doing. And I had come across an article featuring the story of Dr. Brian Forrest, but there was nothing on the Academy website. And I actually mentioned Brian by name, and he happened to be at that meeting, which I didn't know. And, but I put the leadership on the spot, and I said, you all need to be doing something about this, because this is what patients want. Now, I promised that I was going to talk about 3 things in terms of my practice: modern mobile medicine. So again, I served as medical director of Catholic Charities until 2012. I left when I had my 3rd child, one, because I just wanted to stay home. I was tired of working 60 to 80 hours a week, and I really wanted to just enjoy that time with my children. And I had started this nonprofit to educate my colleagues about fertility awareness. I think if you can say one thing about me, what matters, what is the defining or unifying theme throughout my career is empowerment. I believe direct primary care empowers patients to care for their health, and I believe fertility awareness education empowers women to care for their reproductive health and empowers couples to plan for their families without being dependent on drugs or devices or artificial reproductive technologies. So that unifies my work, is this whole concept of empowerment. So I stayed home to grow this nonprofit organization, but I wanted to get back to doing clinical medicine. When I was at the community health centers, I was doing house calls, and I thought, this is a great way to go back into it. I'd been friends with another family physician, Dr. Matt Hayden, since he had done his residency at Georgetown, and he and I were having conversations back and forth. I'm like, Matt, when you are ready, I am ready to join you in starting a direct primary care practice. I said, but I don't want to work 60 hours a week. I don't want to work 40 hours a week. I kind of maybe want to work 5, maybe 10 hours a week. And if you're only going to work 5 or 10 hours a week, you don't want to sign a lease for anything. I mean, that's a huge expense. So we had discussed the idea of doing house calls. What stops us from doing house calls? Well, in the traditional model, if you're doing house calls, you're going to lose a ton of money because you're not running through those patients every 10 to 15 minutes. Well, when patients are paying you directly for their care, why not do house calls? You know, think outside the box. So Matt and I started exploring it. Our big concern was, would patients want this? And I will tell you, the majority of my patients love it. I have one patient who I've yet to see in her home. I've seen her at Starbucks. I've seen her at a cafeteria. She just doesn't, I've seen her at a hotel. Like, she just does not want me to come to her home, and that's okay. But the majority of my patients love it. The other beautiful thing about our practice, as a house calls only practice, there is no overhead. I mean, you need your medical equipment, but I literally still have the same oto-ophthalmoscope that I bought in medical school. Sure, I needed to replace the battery. I have my stethoscope that I've had for over a decade. You know, I had a lot of the equipment that I had previously had. Yes, we had to invest in some equipment. We had to invest in electronic health record. We had to obviously invest in malpractice insurance. But when you look at, in terms of the overhead, the biggest cost of overhead, and I know this when I was medical director, is staff time, staff salaries. Our practice at Modern Mobile Medicine, it's me and Matt. He did finally, in the last 6 months, hire somebody to answer the phones, but I still take all of my own phone calls. Every single one of my patients gets my cell phone number. They call me directly, they text me directly. When I tell this to my colleagues, they're like, are you crazy? That must drive you nuts. But in reality, my patients know they're calling me on my cell phone, so they're really thoughtful. And in fact, I've had to counsel some of my patients, no, if you woke up at 2 o'clock in the morning with chest pain, that would have been a good time to call me and not to wait until like 9 o'clock the next morning when you thought it was like a more appropriate time to bother me. So house calls is a unique feature because your overhead is so low, it allows you to start small, it allows you to start slow. We started Modern Mobile Medicine in 2016. My goal was to enroll 1 member a month. My ultimate goal was to work 10% time. So most direct primary care practices, a full panel is about 500 patients, 600 patients. So I'm thinking I'd like to get to 50 to 60 patients. Well, when you're seeing families, it's pretty easy. Right now, I'm up to 17 memberships. I have about 50 to 60 patients. Last year, I think I saw 56 unique patients. I actually calculated my income for last year, assuming I averaged 1 hour per visit. I made more than double I've made in any other job that I've had. Not only at Catholic Charities, but when I was faculty at Georgetown, when I was doing locums all over the country. I was shocked. I'm like thinking, I'm making all this money and I am having so much fun. I mean, I'm constantly tweeting about my patient experiences because I'm like, this is the best. People actually pay me to come and take care of them. And these are just some of the things that I do. I mean, this is a newborn, this mom. She's reading actually an article. I was quoted in Cosmo. Unfortunately, it was not about direct primary care. It was about fertility awareness, but she was shocked. But that's her newborn baby. This was her 5th child, and she's like, there is no way I am packing up all 5 of my kids to go in to see a pediatrician, you know, at 1 month and at 2 months. I remember, I think it was his 1-month visit. I went, saw her, did the whole history, everything, had gotten through about 90% of the physical before I actually woke up the child. She's like, so patient-centered. It's all about the patient. So I do newborn care, emergency care, I coordinate care, I do continuous care. Again, because I have this passion for fertility awareness that involves charting, I take time to review patients' charts. This is one of my patients with polycystic ovarian syndrome. Instead of treating her like most of my medical colleagues would by just putting her on the pill and saying, well, that'll regulate your cycles, it doesn't actually treat her underlying pathology. It may worsen her insulin resistance. It may affect her future fertility. I can work with her to do appropriate hormone testing because I have the time. It's comprehensive. I do procedures. This is a toenail removal that I am doing in a patient's home. The patient loved it. The mother loved it. It was easy. It was simple. It was straightforward. I've done a few other procedures. I'm very fortunate in that when I was at Catholic Charities, there was one of the physicians that worked with me who is double boarded in general surgery and family medicine. She's also a retired colonel in the Army and a religious sister. She's about 6'2" and walks around in a white habit all the time. She's a little bit of an imposing figure, but she actually lives in my neighborhood and has a clinic, and so she allows me to come there to do some procedures as well. It's cost effective. I tell my patients the cost to be a patient at Modern Mobile Medicine is what it costs for your cell phone bill. The only difference is we don't charge a termination fee. So for individuals, it's $79 a month for our basic plan. That includes 4 house calls a year, unlimited telemedicine, again, direct texting. For our families, it's $199 for up to 6 family members. We are starting to charge a small fee for family members above that because there's a neighborhood close to me that's a very large Catholic community, and there's a lot of 6, 7 families with 6, 7, and 8 kids. But still, $200 a month, that includes 12 house calls over the course of the year. So literally, I come to your house once a month, and that's included in the cost. So it's very affordable. It's convenient. Again, I meet patients where they're at. I have one person, I always see him at his work. Our official hours are 8 to 5, but my patients call me and I work with them. What works for you? I had one mom call me at 4:45. Her daughter had just fallen off the trampoline, had a laceration on her skull, on her forehead, was like, what do I do? I said, text me a picture of it. I'm like, I literally just picked up my kids from school, so I've got 4 kids in the car. I said, I can come right over, but let me see a picture. She texted me a picture. I'm like, that looks okay. I said, I can, if you give me a half hour, wait until my husband comes home. She's like, well, can I feed my kids dinner first? I'm like, sure. So I said, how about I come over at 7? She said, that's fabulous. Her husband works for the federal government, so he was working crazy hours. Again, she had a few small kids. She did not want to spend, 5 hours in the ER with 4 small kids getting a laceration fixed. I went over there. It was very simple, small, just required some Dermabond. It didn't even need stitches. So very convenient. And I'm a part of my community. I like to think of, I'm a little young for Marcus Welby, but I've heard wonderful stories. Like, I like to think I'm the Marcus Welby of Brookland. One of the disadvantages of doing house calls, especially in Washington, D.C., is you have to limit your perimeter, right? Otherwise, I could spend my day in Beltway traffic. I have no interest in doing that. So I limit my service area to my neighborhood of Brookland and to the neighboring neighborhood in Maryland called Hyattsville. So it's about a 10-minute driving radius. I do have some patients outside of my neighborhood that I will meet, as I mentioned, at Dr. Dee Dee Burns' clinic, or that I'll meet the family I said that I meet at their work. They own a real estate business in my neighborhood. They don't live in the neighborhood, but I'll see them there. So I do limit it because I just don't want to have to drive all over the Washington, D.C. area. But then I get my patients through my community. They've come through my kids' school, through my church, through my book club. In fact, I had a patient, this family, they've got 5 children. The husband actually works in Mali, in Africa. They have a daughter in college in Texas, and then 3 other children at home. And I was at my book club with the mom, and we were chatting, and she had just gotten back from visiting her husband in Africa, and I was like, how's everybody? And she's like, good. She's like, but my daughter, it's weird. When I was away, she was like throwing up for a day, and then it went away, and then she had a fever, and then it went away, and then it came back. I just don't know what's going on. I'm like, any other symptoms? I mean, this is like on the dessert break at book club. She's like, no, she doesn't have any cold symptoms. She's not complaining of anything. And I said, well, why don't you keep me posted? So she ends up emailing me that night. I got home, my daughter had a fever to 102 again. I said, you know what, let me see her tomorrow morning. I'm like, I'm concerned maybe there's a urinary tract infection going on. Sure enough, she actually came over to me because as I was telling you, I was literally leaving to go to Tennessee that day. So she came over. I saw her daughter did a urine dip. It was positive. I said I sent her to the lab to get them to send the urine for a urine culture because this is a 9-year-old little girl. I want to know what it is that I'm treating. But again, it's all about being there and being patient-centered. So advantages of a house calls only practice. I think when you do house calls, you get to know your patients far better than when you see them in the office setting because they can't necessarily hide, their lives. And it's just, I think it's a much more intimate relationship. I really appreciate that relationship. Again, it's in terms of overhead, I think this is ideal for the stay-at-home mom, or the mom with small kids like me that only wants to work a few hours, or for those towards the end of the career that are so fed up with this system, but they're not done with caring for patients. I think this is a great opportunity for them. I think the disadvantages, it's hard to recruit. It was easy for me because I've lived in my neighborhood for about 15 years. My partner, and I'm married and I have kids and I'm well connected to the community. My partner was single when he started and it was a lot harder for him. He also wanted to do this full time, so he was working at an urgent care as he's been gradually building up his practice. Again, just direct primary care in general, it's autonomous, more time with patients, time to research their conditions, challenges, I'm on my own. So in a lot of ways I have to do it all, but that being said, I really don't. Like I said, my sister's a trauma surgeon, so I've called her. My brother-in-law's an ID specialist, I've called him. My kid's ophthalmologist, I called once when I had an issue with one of my kids, and he was so happy to help me. He's like, I love what you're doing. I wish I could do what you're doing. I'm like, you can. It's not just family doctors. It's an irregular schedule because I don't have 9 to 5 hours, but I frankly like that. Recruiting patients can be challenging. And I think for the patients, they're concerned, I need health insurance. So I love the health sharing ministries. I think that's a great model. We talk about catastrophic insurance. So long story short, I think this is a fabulous way to practice medicine. I do not think it's for everybody. My husband, again, family physician, he would hate this. He is a man of order and regularity and likes to walk into the exam room and know where everything is and the patient's been roomed, and that's great. I, however, enjoy the flexibility and the uncertainty. You never know what you're going to walk into. It doesn't bother me. I actually find that kind of exciting. This is just some experiences for my patients. Yeah, so it's been a fabulous experience. I love what I do. I think this is a great model for people to consider. I should say my partner does rent office space a couple days a week because there are some patients that want to see him in the office. I just am not there because I don't want my practice to be that big. So that's us. Thank you.